All right, so welcome everyone. We're going to start seeing people here coming in, and we welcome you. I see the numbers going up. You are in our very first patient-led class. Woohoo! So we are the International Foundation for Autoimmune and Autoinflammatory Arthritis. We say AiArthritis for short. My name is Tiffany Westrich-Robertson. I'm the CEO of the organization. I'm a person living with non-radiographic axial spondyloarthritis. And I'm really excited because you may not know I was a college teacher for 10 years. So I feel all back in the classroom and I'm excited. I am your instructor today, and I'm joined by a couple of our staff and volunteer who are serving as our discussion group leaders. So I'm going to have Deb, you introduce yourself first, then Michael.
Absolutely. I'm super excited to be here as well. Hi, everybody. I am Deb Constein. I am in the Madison, Wisconsin area, and I was diagnosed with RA at the age of 13. So over 40 years of dealing with this, I guess we'll say, and longtime volunteer for AiArthritis. And I'm super excited for this classroom. I love this. My bucket is always learning, and I'm a dietetics and biology majors from college. So this is in my wheelhouse. I love it. Michael.
Hi, I'm Michael Guadalupe. I am one of the volunteer and administrative assistants here at AiArthritis. Not only do I work here, I also am a patient. I have psoriatic arthritis. I was diagnosed when I was 14 years old with psoriasis, and I probably had psoriatic arthritis about 5 years before I was actually diagnosed because I was too young. I was like 26, 27, and I started having the swelling, and I let that go for about 10 years because I just didn't know to ask questions. So I was diagnosed about 10 years ago with psoriatic arthritis. I am happy to be here and hope to learn a lot about precision medicine because I think this is the future, and hopefully we can bring it sooner than it's scheduled to be.
Awesome. I am going to share actually, I'm going to stop sharing and then reshare because I didn't share my sound. And we all know what happens when you don't share your sound. You're not going to be able to do the video. So let me try that one again. All right, here we go. All right, so today's lesson, precision medicine. And Lisa is actually in the chat now. So we're going to have Lisa also on camera as a discussion leader, and she is now in the chat. So hey there, Lisa. I also saw some others from our Knowledge is Empowerment volunteer group. So this is a part of our Knowledge is Empowerment patient-led public policy education and action program. And we are really excited because what is more exciting when you go to class but to have a class speaker? So in addition to giving you a little bit of a lecture time, breaking out into discussions, we also are going to welcome Hillary from the American Cancer Society, who is going to talk about how this all relates to access to our treatments and getting the right one at the right time for each of us. So we're excited to bring Hillary on in a little while as well. All right, we also have to thank our project supporters. And let's get started. So how to participate in the class. If you haven't found already too, on your Zoom screen, there is an option for closed caption if you need to do that. We have a glossary. So Miss Deanne, we're going to give a call out. Deanne is another one of our staff at AiArthritis, living with rheumatoid arthritis. You may see a pattern here. All of our leadership are affected in some way with our diseases, which makes us pretty unique. In saying that, there is a glossary. So there's also a patient-led glossary. It is a living document, which means we don't know every word, every term that needs to go in it. So we did start it, but if you hear something that we say and you're not sure exactly what it means, go ahead and feel free to put it in the chat. Also, we provided Michael's email for you. You can, in the subject line, put glossary, and you can be part of helping us add terms to that. And the glossary will be available for all of the classes that we do in this webinar style, but it's also available on the classroom website, and it'll be available anytime you feel like you just need to check that out so that you know the terminology that we're using. How are we going to do this today? Well, there's all kinds of ways to learn, right? So we're going to mix it up. We're going to watch, listen, learn. We're going to discuss, listen, learn. We really want you to use that chat feature, because class discussions aren't any fun if not everybody's talking, right? So feel free to please use that. Class doesn't have to end just because the webinar does. There's a QR link here for you. It'll also, the direct link will be put in the chat. And there is more to these classes than just these 4 webinar classes that we're doing over the next couple of months. We have best part of class, right? So one is starting next week. Join me in Washington, D.C. and several different meetings and conferences that I'm going to. But anytime there's a public policy related, legislative related conference or meeting that one of our team from AiArthritis is going to, as part of this project, we're inviting you along virtually, of course, because you can't pay for everyone to go. And then there's elevated experiences, which is a level 2. So if you love this, make sure you've registered for the Knowledge is Empowerment using that QR code to see the classroom. Click the button to register, and you'll just be alerted of all of these amazing opportunities automatically. All right, so what are we going to talk about today? Precision medicine. As we said, here is our lesson outline, and we're going to go ahead and get started. All right, I keep having to move my little faces around here on my screen because I don't know what they're going to cover up and you can't see. All right, what is precision medicine? So how we're going to do this is I do have a video. Now in this video that we're going to play, it is also part of, hold this over, this YouTube channel. So all of these amazing faces that you see here are all people living with our diseases. And we have many videos. So I'm focusing on these that are in precision medicine. And that's where you can find the whole list. In saying that, a lot of what you see here written is going to be stated in the video. So we're going to go ahead and we're going to play. You can read. And then we're going to also look at one more video on why precision medicine is important, and then we're going to discuss it. All right, so I'm going to go ahead and hit play. Precision medicine is tailoring your medical care to your own individual biology. Now, while some people do still interchange the words precision medicine and personalized medicine, personalized can often be more of like a customized treatment plan. So it could include diet and exercise, that kind of thing. So precision definitely is referring to something that is more scientific, like your DNA or biomarkers, which could be in your blood or bodily fluids or tissues. It is a way for doctors and researchers to understand your own genes, what's happening in your body, and that information can then provide more direction for how to treat your disease best in accordance to what will work best for you. When we're talking about biomarkers and other factors associated with precision medicine, what's really important for us to understand is by putting us into more subgroups instead of part of this broader population, we can start to narrow in a better likelihood of early diagnosis. So this group of people tend to have these certain signatures in their biology. That could lead to, it might be this diagnosis. The other thing is it could determine if you're going to have a more aggressive disease path or likely to. So that's important to know, right? When you have a treatment plan that's being put together. Another is it could potentially identify what treatments you're going to respond to best. Not having to do all of this trial and error to actually know right away. And if you were treated with the right treatment immediately, you have a much better chance of going into remission. A word, unfortunately, we don't hear a whole lot in our community, not as much as we would like. All right. So, in saying that, that is a little bit of a definition about what precision medicine is. And the things to really pull out there, I think, is the difference between personalize when we're talking about exercise or lifestyle. A lot of doctors have said, "Oh, I've done precision medicine or personalized medicine for a long time," but what they're saying often is matching to lifestyles. So that's a really important thing to know. And then also just really understanding that the reason too that we're having a speaker from the cancer world come in is because precision medicine is in the cancer space and it's new in rheumatology. So we're in our infancy, and the amazing things that can happen if we have access to it, it's amazing, including remission, which I just find amazing. It's a word that I never thought I would even be able to say in my lifetime. And now precision medicine is making that a reality. But that same type. All right. So why is precision medicine so important to rheumatology, and why should you care? In the chat, I'd like you to say, why do you think precision medicine is important to you? We're going to hear from Carrie on why she should care, why she thinks we should care.
Precision medicine can help us get diagnosed more accurately and get the most appropriate treatment sooner. That gives us a greater chance of achieving remission, which can be life-changing, both physically and emotionally. It can even save money for the healthcare system if we don't have to be on expensive medications for the rest of our lives.
Right. So some major points to consider when we're talking about why is precision medicine important. Trial and error. 3 to 6. How many of you, including Michael and Deb, are on biologic treatments for your condition? I am as well. Yes, yes. Okay. How long did it take you for these medications to take into effect? Michael, how long does it typically take, or how long have you been on yours?
I'm actually lucky. I've been on mine for 10 years, and so far it's been working. It took about 2 months for me to notice a difference. But again, my condition was fairly mild since I was living with it, but I did notice within 2 months.
All right. And I know, Deb, I'm going to give you a feature spot here in a bit to tell your story, but just to answer the question here, a trial and error I know is a big deal for you. How many medications have you been on?
All of them. All of them. So and a couple of them I'm on the second time around. Although I did just start a newer medication and I'm 2.5 months in and life sucks.
So think about that.
Anywhere to 3 to 6 months is average for all of my trial and errors.
Absolutely. And less cost to the healthcare system. So think about if you or me or Michael or anybody out there with our diseases, it is not uncommon, especially if you miss this window of opportunity. There is a window of opportunity that the American College of Rheumatology and EULAR, who are the governing scientific groups around our diseases, say 6 months from onset of your disease. And that is the best chance for remission. Go forward. All right. So we're going to jump in and talk about this a little bit more, class discussion. But this whole concept, I can't figure out where to put our little faces without covering everything up. I'm going to move us over to the other screen for me so that everybody doesn't have a black spot in there. So talking about what we just saw or what we just learned, I'm going to ask first, Deb, in your own words, what is precision medicine?
I would probably have to say, so precision medicine is using my lab work, so blood, and being able to have the professionals determine which medication is most appropriate for me, that is going to work for me the first time and every time. So that is remarkable to me. And I can't even fathom that at this point, because I've been doing this for so long. But it still gives me great hope. I'm not over the hill yet to where I've given up or anything like that. Little just like unhappy with where I'm at this point right now. But there still are more steps in my journey, and more medications are being made every day. So that gives me hope too, that again, still that precision medicine will help improve my life.
Absolutely. Michael, what about the second question here? Why do you care about precision medicine? What's exciting about it for you?
Well, me on my end of it, what I care about is trying to give patients a chance of getting into remission quickly. Plus, even if they're not in that first 6-month window, to have a good shot at remission, at least get them started on treatment early, so they don't have degeneration in their joints. So they have a better quality of life. That's why it's important to me. Plus the cost factor. I've read a lot of research on the cost factor of precision medicine and learning early and treating early.
You know, it's just kind of an interesting point too when we talk about price, because these medicines that we're on are not inexpensive by any means. So let's just use a roundabout number and say $50,000 that it costs us with our biologics and any other care, times that and early onset. So most of us have onset between 20 and 40 years old as an adult, and any age as children. Doesn't mean it can't start at any age, but that's just the average onset. So if you're 30 and you times that by 50,000 and you live to be 90, that's an awful lot of money for the healthcare system, right? So that the issue, a lot of the issues though, is in the healthcare systems. They look at an annual budget. They need to be cost efficiency thinking on how they're going to contain the budget for this year. So that long-term versus immediate cost doesn't always factor in. And that's something we really have to think about and talk about when we're talking about precision medicine. And also, I think for me, why I care so much also is kind of writing on what Michael said, in that if people could access these their treatments early, or even you have biomarkers that diagnose them earlier. So we're getting diagnosed earlier. We get matched to treatments that might work or not work. So we'll talk about some tests that are actually out that could teach you, show you and your doctor before you try this 3 to 6 month trial and error. That's just adding on to the lower chance of achieving remission, that if we could have access to these types of treatments, that we could definitely have better outcomes. Deb, did you want to say a little bit more about your story? Because I think it's very relevant.
Sure. So I actually had a trigger that caused the onset of my rheumatoid arthritis. I went in for a very benign surgery. It was a bunion surgery, and it's kind of a genetic foot deformity, and it was causing a lot of rubbing and discomfort. Had I known that having that surgery was going to introduce my life into all of this, I may not have had that surgery, and also make my foot look better. But it's been an interesting journey, because being diagnosed at 13 back in the day, there weren't pediatric rheumatologists back then, so it was an adult rheumatologist, and I actually hated my rheumatologist when I first met him, because they're doing the joint count and they're pressing on every one of your joints and everything hurt. So I was not a big fan of him causing me that kind of pain at the beginning. But I've been on gold treatment and handfuls of aspirin and all kinds of different treatments. And once the era of biologics actually happened, I can easily say that I'm still fixing what the first 20 years of bad medication caused my body. I haven't had any further destruction in my joints since I've been on biologics, and I've been on all of them. As far as pills and infusions and pen injectors, my hands are probably the one thing that makes life even worse at this point, just because my husband does all of my pen injectors. To hold comfortably a pen injector, it just doesn't work. And my husband also gives me my methotrexate shots once a week. So we often have a joke that not to get into an argument before it's shot time, because he'll hold it like a dart, jokingly, and he's like, ready? And sometimes it catches me in a mood where I'm like, no, I need a glass of wine, or we need loud music, or whatever it is. And I do feel for him. We've been married for almost 30 years, and he's been the administrator of all of my meds, like injections and things like that. And some of them really hurt and burned. And there was one that it was 2 shots in a row. And that was incredibly rough too, because not only am I getting over the stinging and burning of the first shot, I've got another one to go. So they were back to back. And I've also gone back on the medications that lasted longest. So I had a second trial of Humira, which lasted 7 to 8 years. And Actemra was one that I chose to go off of because my lipids skyrocketed. And with my history, I didn't want my family history of heart disease and things like that. I didn't want to further that problem. So I did go back on Actemra, and during COVID, and actually had all kinds of issues with getting it, because Actemra was also being used for COVID during COVID. So it was taken away from me, and I was given the less effective form of pen injector versus infusion. If I'm given a choice, I tend to personally get the infusion, because I think that the impact has been better for my body. Again, everybody's different. So I just want to point that out, that what I'm saying worked for me doesn't always work the same for other folks. The next retrial of medication that I will probably end up going on sooner than later is going to be Rituxan, which is a B cell inhibitor. I've been holding off going back on that because I have to be off of all meds for my immune system to regenerate all of my T cells before I start destroying the B cells. So I've got to regenerate the it's unique as far as a B cell inhibitor goes, because that will go after my B cells and diminish those in my body. So it's always trial and error. And again, you know, Tiffany's got up there. I've been doing trial and error most of my life, and it's definitely a long journey. And I have been diagnosed as far as difficult to treat. So they have it at EULAR, they call it D with a 2 and then a capital T. So difficult to treat. And I've had difficult to treat RA for many years, and again, significant disease.
So the reason that I pulled this over, this is our glossary. And so we had given you a link, and these are the types of terms that you'll find in it. So it's important for us as patients to know what difficult to treat means. It's actually something that was classified just recently, and it's a person who has failed more than 2 biologics. How many people here have failed more than 2 biologics? Michael's not, but look at the percentage here, right? So that just tells you why, when we're talking about the need for precision medicine, when we're talking about the need for access to the right treatments, what can happen if you do not get access and you become difficult to treat. Not only does remission become less a possibility, but we develop comorbidities. And when we develop comorbidities, these could be additional diseases. This could be heart disease. They could lead to other things that are all based on inflammation or inflammatory markers. I did want to throw this up. It's just an example. And this is something that is actually out today. It is not necessarily accessible for everyone, but it is. I saw Lisa shared her story in the chat, and thank you for doing that, Lisa. And she said, what if I didn't do well on TNF inhibitors? And a TNF inhibitor is really just one of the mechanisms of our treatment that target certain molecular signatures. And so the thing that's important is TNF inhibitors are your first line treatments. They're your Enbrels, they're your Humiras, okay? So in most of our diseases, it is a first line treatment. So what if you could know ahead of time if you would actually respond to it or not? So there are tests, and this is just an example of one. There are many out there with simple blood tests or biomarker tests that they can test to see if the percentage of you being able to respond or not respond. And there is another video in that Abby and I were talking about. So if you go to that library of videos and you look at the one for precision medicine patient story, Abby's perspective, we go into this particular study in a little bit more. But the question we have for everybody, what do you feel like a test like this would have helped you? I think, Deb, you've answered that question.
Yeah, 100%. And the one thing I did want to just mention as well is when you're still in bad control and you're waiting for these medications to work, there's destruction still happening. So saving your body and actually finding the right medication right away could have saved my hands. I have a fused wrist, so it doesn't bend. Just my mobility. I'm clumsy because I'm dropping things all the time. So that's another piece that once it's gone for good.
Mm-hmm. Absolutely. All right, so we're on to lesson number 3, and this is the last lesson before we bring on our class speaker or guest speaker today. So we're going to talk a little bit about why all these stories matter. And this is sort of the listen, learn, and share part of it. So I think what patients need to realize is nothing can replace lived experience. And it's important for anyone who's going to be deciding the fate of our treatments to know what's important to us. They also need to understand, we use the term general patient population, which if it's not in the glossary, it will be in the glossary. So the general patient population, this bullet number 3, is really important for patients to know, especially when we're talking about sharing our stories. So essentially, the way that our treatments work is they go into clinical trials, they go into research, and there are thousands of people who are tested, and then these treatments say, yes, it passed, it did well with a very large percentage of these people, it makes it to market, and we are thankful for that. So we have several of these options, right? Well, the thing about clinical trials, which is now changing, by the way. And side note, if you have never been in a clinical trial, they are shifting. It's becoming more precision. They're starting to use more subgroups because historically they would pick people to be in there that met the standard textbook. A lot of times, never been on a biologic, definitely not having comorbidities. So that knocks you out. So what often happens is the biologics that make it to market might only be effective for 30 to 40% of us. That's why somebody like Deb might say, I tried the same one you did, Tiffany, and it didn't do anything for me. And I'm like, yes, it was amazing. So we've got to start really pushing for access to the right treatment for us, for all of the reasons that we've talked about before. And so that is just really, really an important part. I'm going to play a segment from Brittany's video because she did a little education herself and I just really enjoy hers. But this is another example of why Brittany's perspective and she feels it's important.
I've had psoriatic disease for over 20 years and have tried 7 biologics among many other treatments. With the absence of precision medicine, I've had to test my own immune system to see what is triggering my disease. Note that trial and error with treatments is often the only plan of action, but it's painful and sometimes makes things worse instead of better. Next to me, you can see the 7 different biologics I've taken, what type they are, and how long I took them for. TNF inhibitors have been on the market the longest and are the tried and true biologic for psoriatic disease, or so they say. For me, TNF inhibitors actually cause my psoriasis to flare and do nothing for my joints. But as you can see, I've tried 3 of them just to see if maybe one would work, especially since it was over a decade between the first TNF inhibitor and the second. Taking TNF inhibitors out of the mix leaves me with interleukin inhibitors. Stelara was by far my favorite. Stelara targets interleukin-12 and interleukin-23. My skin was clear for almost 7 years, and I had little arthritic disease progression. Unfortunately, over time, my body seemed to develop antibodies to Stelara, and my arthritis progressed, so it was time to seek a more effective treatment. Cosentyx targets interleukin-17 and gave me about the same relief as Stelara. It worked for my psoriasis, but didn't stop the arthritis flares, so I kept looking. Tremfya targets interleukin-23 and was my saving grace from 2021 to 2023. My arthritis flares slowed, and my skin was fairly clear, and my fatigue had dwindled. Tremfya worked really well, and I thought it was going to be my next Stelara. Unfortunately, my body chose to build antibodies during a 4 to 5 week period, where I was waiting for my prior authorization to come through, and the drug never worked the same again. This brings me to where I am today. I've taken one of the starter doses of Skyrizi, which also targets interleukin-23, and I'm crossing my fingers. From here on out, I will be watching the market for new FDA-approved biologics for psoriatic disease that target interleukin-12 or 23. So to wrap this up, without precision medicine, I have spent 14 years testing out biologic treatments. Some have worked, some have caused flares, and some have done nothing. There are other factors that contribute to the success of your response to biologics. Most important to me has been interruptions to doses due to illness, vaccines, or insurance. This DIY precision medicine process causes stress and anxiety and requires you to be 1000% engaged in your care. Most of the time, I've had to do my own research to bring these treatment options to my doctor. When you hear those commercials saying, at your next appointment, ask your doctor about XYZ drug, I think that's ridiculous. The doctor should be suggesting treatments that would be good for you. But at the end of the day, they have the same data you do, and sometimes less than you do if you don't share everything you're experiencing with them. So take control of your care, advocate for yourself and for precision medicine, and stay hopeful. Thank you.
I just want to clap. I just want to clap.
All right. And so as I'm going to be zapping our speaker in here just a moment to be a panelist, but I wanted to also just remind everybody, stories do not have to be on camera. So at AiArthritis, it's very, very important for us in the work that we're doing to ensure access and to make sure we have to have your voices, all of our stories, not just mine, not just Deb's, not just a handful. We need as many stories as possible. Not everybody is going to be comfortable being on camera. If you are, great. let us know, because we're building out that library, and we can use your story on camera, but you don't have to be on camera. So there's a lot of, it's very simple. It can be just a couple statements like you see here on the screen, or you can submit much longer stories, but we collect all of them. All of them come with us when we advocate for access. So we definitely encourage you to start thinking about how precision medicine either has affected you. Maybe you've had biomarker testing, maybe it's helped you get a diagnosis, maybe you can think about how it could, because we are in a very different stage than in the cancer community, which we're going to hear about next. But I'm really excited to bring that speaker on. So I'm going to find her in our group here. I'm going to zap her on. I'm Miss Hillary, but I did want to show that all of how we're starting to unite. So you can see the cancer world and other diseases that precision medicine is moving into our space. I highlighted in yellow the groups that are in our specific rheumatology space, and you'll see we are the ones that are really trying to lead the space, we meaning the ones that are highlighted in yellow. So let me bring up Hillary. I'm going to make her a panelist. And should be coming up here. Let me unshare my screen.
Hello, everyone. Hey, Tiffany. So excited to be with you all today. I'm Hillary G. Geckner with the American Cancer Society Cancer Action Network, or ACS-CAN. We're the advocacy affiliate of the American Cancer Society, and I work primarily on state legislative campaigns around access to care and biomarker testing. So I'm super excited to partner with you all and be here today. Let me pull up a few slides.
All right. I'm going to put myself on mute and give you the floor.
Great. Thank you. So as Tiffany previewed, there are enormous applications and really exciting breakthroughs happening in cancer treatment thanks to biomarker testing and precision medicine. And that's great, but oncology is also leading the way for applications and really exciting research happening into almost every disease area. So I'm super excited that the work that we are doing at the state level is not just to benefit cancer patients, but will ensure that other disease groups can benefit as well. So I'll talk a little bit about what precision medicine and biomarker testing looks like in cancer, hopefully as a preview for what more treatment will look like for other conditions in the years and decades ahead. So as we've heard a bit, biomarkers are something that can be measured from your body. And often in cancer care, we're talking about gene mutations or protein expression. And this helps doctors prescribe the right treatment at the right time, but also avoid treatments that won't be helpful or will be harmful. And that's really important. And this is far beyond cancer. Current applications are overwhelmingly in oncology. However, there's so much research happening and lots of clinical trials are now focused enrolling people based on their markers. So what does this look like in a cancer patient? Rather than just treating the body part where the cancer is found, biomarker testing allows doctors to understand kind of what's happening at the cellular level in the cancer cells to drive that cancer. So instead of saying, you have lung cancer, let's try any of these lung cancer treatments and we'll do trial and error, see what works. Instead, with many, though not all cancers currently, a tissue sample is taken often from a biopsy. That is sent for biomarker testing to look for different markers that are known to respond to certain drugs or tell doctors how a cancer will act. And then if one of those markers is found for which a treatment is available, that treatment can be prescribed. So instead of everyone with lung cancer can try these things, people are subgrouped into, you have, in this scenario, an EGFR positive lung cancer. Therefore, we will prescribe you one of these EGFR targeting drugs. And these targeted treatments based on patients' markers not only help them live longer, but often have significantly fewer side effects because they're targeting that marker, whereas more generalized cancer treatments kill all fast-growing cells, which is why they can cause such devastating side effects. So all of that sounds good, right? We all know people with cancer. We all want patients to get the most effective treatments. First question is, who should be getting this testing? In oncology, doctors rely on clinical treatment guidelines, like many disease areas. This is not specific to oncology. So for biomarker testing, we most often hear about guidelines from the National Comprehensive Cancer Network, the Society for Clinical Oncology, and the science is moving really quickly in this area. So those guidelines are updated regularly and help providers keep up to date with the science. And in many cases, this type of testing is really standard of care for all patients or patients with certain characteristics, certain staging. And these targeted treatments allow patients to often live better and longer. Unfortunately, like in many areas of healthcare, not everyone who should be benefiting from these latest advances and treatments is actually getting them. We see a lot of the same disparities that we're all familiar with across healthcare and cancer outcomes, certainly in access to biomarker testing as well. So patients who are Black, insured by Medicaid, have lower incomes, and also patients who are receiving care outside of academic medical centers are all less likely to benefit from appropriate guideline-indicated biomarker testing. And so what this can actually do is increase the disparities we already see in cancer survival by limiting kind of who's able to get the best and latest treatments to patients who are going to the right center, who are able to pay out of pocket for them. And for biomarker testing in oncology, some of those tests can be upwards of $10,000. And one of the challenges contributing to those disparities is coverage of needed testing. So whether or not an insurance company will pay for that testing. And there are lots of different types of biomarker tests. Some are looking for a single marker, a single gene, and those are not very complicated and not very expensive. It might cost an insurance plan $40, $50. Whereas, as I mentioned, some of the much more complicated large panels looking for many different markers are much more complex and more expensive and can be thousands of dollars, kind of sticker price. And if an insurer says, we won't cover this, we think this is maybe experimental or unnecessary, or you should start with this cheaper test first, patients who are already dealing with all the out-of-pocket costs associated with their cancer care can have a hard time deciding, or might not be able to even entertain the idea of paying thousands of dollars out of pocket for this benefit that's not covered. Even though the testing results might end up saving the insurer a lot of money by avoiding drugs that won't work, or avoiding a surgery that's not necessary. So one of my colleagues worked on a paper recently that compared the insurance policies, kind of written policies in each state to those clinical treatment guidelines from NCCN. And although most of the policies said we consider what NCCN says, most of them weren't actually following what was in those guidelines for advanced lung, breast, skin, and prostate cancers. So these are really proven applications for late-stage cancers where there is very clear clinical benefit to having this information, matching patients with the right treatment. But majority of plans were more restrictive and not covering testing in their written policy for patients who needed it. So what does this insurance company saying no mean for a patient, or saying you need to do the cheaper test first? We put together some patient profiles. These are hypothetical patient stories so that we can see both scenarios. What does it look like when she gets the testing? What does it look like when she doesn't? So this is Kathy. Unfortunately, she has no face, but she seems very nice. She was diagnosed with stage 4 non-small cell lung cancer after seeing a few doctors. If her insurance does not cover the right testing, so she's diagnosed in January for convenience, so we can kind of look at a plan year. Her insurance says, no, we won't do that larger panel test that will look at many markers. We're instead going to pay for 2 single marker tests for the most common lung cancer mutations, ALK and EGFR. Biomarkers are typically notated by 3 or 4 letters and numbers just to make it confusing. And so they look just for those 2 more common mutations, don't find any. So she starts chemoimmunotherapy just to try something, see if it might work, trial and error. She goes to the emergency room because she's having shortness of breath. Scans show that her tumors are continuing to grow. The chemotherapy isn't working. And so they do another biopsy, another surgery to get a piece of her lung tumor to test for a different marker, looking for an RET mutation. Nothing is found. She starts another treatment, another few months of trial and error. Because of the side effects of that chemotherapy, she has to stop working. And it's also not actually doing anything to help the cancer. Her tumors are continuing to grow, so she switches to another treatment. Then in November, they do an additional biopsy and test for 4th most common mutation in lung cancer, ROS1, and find that she has that mutation. And that mutation responds really well to targeted treatments. And so she starts the right treatment in December, and her disease stabilizes. Now, in a parallel universe where she got the right testing up front, they did a comprehensive panel that cost the insurance company a little bit more, but provides much more information. They find that rarer mutation up front, and she starts the right treatment right away. She doesn't have 12 months of cancer progressing and growing like any other, progressive or degenerative disease. And she isn't going through all of those treatments that aren't not only not treating the cancer, but are also making her feel awful. And she had to stop working. She's going to the emergency room. There are a lot of costs to the system, in addition to kind of the inefficiency of paying for healthcare that isn't making her any healthier. So obviously we want Kathy to have scenario B there, where she gets the right testing up front. So ACS CAN has been working with many partners, including AiArthritis, to pass state laws to require more insurance plans cover this testing when it's supported by the evidence. And so this is looking at all of the insurance plans that are subject to state law, which is not actually all insurance plans, but various insurance types. So this is private insurance that people buy on the marketplace, that are provided by small employers, that is available to state employees and state Medicaid programs, and requiring them to cover comprehensive biomarker testing for any disease type or stage when it meets the evidence that's spelled out in the bill. So that's clinical practice guidelines like those I described, FDA approval of tests, or also often the FDA will approve drugs with a companion diagnostic. They'll say, in order to receive this drug, you should be tested for this marker. So that's another source of evidence for when testing is covered under this legislation. And over the last 2-3 years, we've had enormous success and progress on this. You can see here, 12 states have now enacted this legislation. As of about 9 p.m. Pacific last night, California also passed this legislation. So in both California and New York, that is awaiting the governor's signature. And then legislation has been introduced in all of the blue states you see here. And while most of those legislatures are done this year, those will be continuing as we get into 2024. As Tiffany highlighted earlier, there is huge enthusiasm across disease types. There are dozens of patient and provider groups involved in this work nationally, and additional groups involved in each of those state campaigns. So I'm running out of space for all of the logos. Apologies for the squishing. And so just, want to encourage you all to get involved in legislative opportunities as you can. As we've heard already today, sharing your story is so powerful. when we talk about precision medicine, personalized medicine, biomarker testing, it can sound kind of sciencey and lawmakers can glaze over, but patient stories and your personal experience is really, really valuable at bringing that to life for lawmakers. And they see, oh, you got this devastating stage 4 lung cancer diagnosis, and you were told you had 3 months to live, and here you are 5 years later thriving. That is powerful. That makes the issue stick in a way that hearing the stats and scientific explanation doesn't. So your story is really powerful, and we have lots of opportunities to get involved at the state level. So encourage you all to check out fightcancer.org, and I'm happy to answer questions.
Thank you, Hillary. Thank you. Thank you. So we do have a couple of questions. One of the things that I also wanted to ask, just to piggyback on the legislation part of that, one of the things that AiArthritis and some of the other autoimmune groups and arthritis groups that you saw listed on there that we've been fighting for and that we really need help with, is some of those states that we were seeing are fighting back and saying, okay, well, cancer only, let's wait to see what happens in autoimmune. Do you have any, I don't know, suggestions, or what kind of stories could people give to help with that in particular?
Yeah, it's a great question. So I'm happy to say all of the 12, soon to be 14, knock on wood, states that I highlighted on the map all passed disease agnostic legislation. So although we are part of the American Cancer Society, cancer is kind of our thing, we are really advocating strongly for the inclusion of other disease groups. We're doing this work in coalition, but also cancer patients aren't just cancer patients. They have other diseases and comorbidities, especially as patients are living longer after a cancer diagnosis. And so they get arthritis, they get preeclampsia, they get lots of other conditions that would also benefit from applications of biomarker testing. And so it's just really, really valuable to have stories and advocates involved so that lawmakers aren't just hearing from the American Cancer Society about this and cancer volunteers who are fantastic, but they need to hear the enthusiasm and the support and the pressure from other groups as well.
Great, thank you. We have a few questions that came in, so I'm going to, the first one from Bridget. Hey, Bridget. So have these tests restricted access to any therapies? For example, I've had 3 genetic tests claim I wouldn't be compatible with a therapy and be very wrong. Would a patient be restricted from trying a therapy they tested incompatible for?
So I'm not totally sure on that.
I'm not either.
But I mean, nothing in the legislation or policy is intended to restrict access. It's more to identify kind of which treatments are most likely to work for a patient or which are potentially dangerous. I think there might be labeling indications. Certainly when we think about pharmacogenomic testing, which is a type of biomarker testing that looks for inherited gene mutations that show a therapy would be dangerous or contraindicated, for a particular patient. That's important to know. But if a test shows that something probably won't work and then it did, I am not sure that receiving the test would necessarily prevent the patient from getting that. It might be an indication that another drug might be appropriate first, but I guess that would depend on the drug specifics and labeling indications and guidelines.
Yeah, that's, and our rheumatology community is still so early in this as well. And I will really quickly just plug also that AiArthritis has started our own research database that is housed under the servers at Forward National Data Bank for Rheumatic Diseases. So thank you to them. And it's going to be predominantly all about how people respond to therapies, identifying subgroups, and precision medicine, trying to really get that data we need to influence public policy. So we will definitely give everybody some information on joining that. There's Oh, go ahead.
Oh,
Go ahead,
I
Hillary.
was just going to add on that. I think there's also a lot of really important applications for clinical trial enrollment and kind of understanding the findings of clinical trials. So historically in cancer, clinical trials were largely driven on the body part where cancer is found. Like here's a breast cancer trial, here's a lung cancer trial, here's a prostate cancer trial. Now, increasingly, trials and drugs are looking at markers. So if patients have the same biomarker that appears to be driving that cancer's growth, regardless of where they are, where it was found in your body, it might respond to the same drugs. So I think in that scenario, that information might also be helpful. You know, maybe there was information at one point that people with certain markers were not responding well to a drug, but you know, if further trials might find that maybe that information was inaccurate or could be updated.
Yeah, absolutely. And so one of the things I just wanted to mention, and you said in the very beginning too, everyone with lung cancer, try this. That's how it started. And that's where we are. It's like, I see. And that's what I really want everyone to also know why we wanted Hillary on here. We are right behind what's just happened. And so understanding what's happening or happened in the cancer space, I could easily fill in the steps and say, well, that's us now. Everyone, and that's what we meant by that general patient population, understanding and getting involved, story sharing, but also any type of data collection to understand who is becoming a subgroup is going to be vital. So research is vital to pushing the needle to access, for sure.
Yeah. And along those lines, you know, I talked a lot about targeted treatments based on particular markers. Biomarker testing is also really important for diagnostic testing and prognostic testing. So diagnosing more accurately what a disease or subtype of a disease is can help inform treatment options, in addition to kind of, you have this marker, therefore you get this therapy. Also, biomarker testing can be really helpful for understanding a patient's prognosis, which certainly when we think about cancer can really impact, but I imagine other diseases as well, how aggressively you want to treat and also kind of how you manage the rest of your life. So if you get a biomarker test that says you have a really, really aggressive disease, you're likely to have, you know, recurrence and metastasis very quickly, you might decide to quit your job. You know, you might decide not to pursue an aggressive treatment, or maybe you do all the treatments that are available and do whatever you can because you know this is aggressive, or you find a clinical trial. Whereas if someone has a much less aggressive disease where they aren't likely to see that progression, they may opt to, you know, not have an invasive surgery that could have a lot of side effects and just get frequent monitoring, kind of watchful waiting, even with a cancer tumor. If it's not going to spread, if it's not going to, you know, cause you to die any sooner, some patients are able to just leave it alone.
Absolutely. Okay. Well, in the interest of time, Hillary, we are going to need to stop the questions, but we're still collecting them. So if there's other ones that we can answer after the fact, we will certainly do that and send those to everybody. So thank you again so much for being part of this. And if you need to jump off, by all means, we're going to wrap up, but you're also willing, you know, welcome to stay on. So, but we appreciate everything and just thank you for that, being a guest speaker today. So we're going to jump in here to the end, and I just wanted everyone to know there is an action plan. So as Hillary has talked about, all of the amazing work that they are leading through this Biomarker Access Coalition, AiArthritis is right there front and center. So the things that they're sending to us to help, we trickle down to you. So there are a lot of ways. So please sign up for this Knowledge is Empowerment patient-led public policy education action program. As you can see, there's different levels. You can sign up to learn. You can sign up to get access to more classes and webinars, field trips, elevated experiences, learn how to write letters, learn how to share your stories, or just simply submit your story like we showed earlier to us, and we'll take the story for you. So there's different levels based on your level of comfort. So just going to ask everyone kind of in your head, and we'll send these out to you afterwards as well to quiz yourself. So ask yourself, do you have an understanding of precision medicine and the difference between a personalized therapy? Can you name at least 2 reasons why precision medicine is important for people living with our diseases? And can you ask, do you feel confident that you could give a personal example of how it has either impacted your life or how it could? If you can answer any of these questions, then well done, you get an A+. You answered all of them. So in closing, we just want to thank you from AiArthritis, and I have to give a shout out to all of our Knowledge is Empowerment patient committee, all patient committee of our AiArthritis volunteers who helped put this classroom experience together, from the videos to the glossary to everything that has now come together with the web, and there's more to come. So thank you, Deb, Lisa, Carrie, Brittany, Jody, Abby, and Patrice, and of course, Michael, who, well, and I'm on there, but I'm in part of it, and then Michael and Christina and Ryan are a production team who help with the videos, and to Deanne for helping today in the chat. So thank you all so very much, and we really hope that you have a great rest of your day, and let us know if you have any questions. Till next time. Bye, everyone.
Thanks for coming.